Well, good afternoon, everyone. Thank you for trickling in on this Tuesday. My name is Sridevi. I used to be one of you 5 years back. I was an internal medicine resident at the then Mount Sinai, St. Luke's and Roosevelt. I kind of refused to call it Morningside. Sorry, it changed during my final year. So yeah, I am a product of Morningside and West, and right now a second-year hematology oncology fellow at the Icahn School of Medicine at Mount Sinai. The chiefs had asked me, I think around 6 months ago, maybe, to talk to you specifically interns regarding leukocytosis and neutropenia. Hence, this is a very, I would say, PG by 1 centered talk. So if you have any questions and if you need any clarifications on any topics which you have seen on the inpatient wards or the outpatient clinics, or if for prospective oncology aspirants, please feel to interrupt me, raise your hand, ask me questions, and take it away, okay? So this is meant to be a primer into both leukocytosis and neutropenia, because I wasn't sure if the chiefs wanted me to do either, so I decided to do both for all of you. Okay, so just moving on, I just want a quick poll, and feel free to like unmute yourselves and tell me, and this is very basic. Do you guys know how to interpret a differential in CBC, correct? How comfortable are you on a scale of 1 to 5? Can you like put in the chat or shout out some things? On a scale of 1 to 5, 6, 7 looks awesome. So I'm guessing it's a scale of 1 to 10 now. Okay. Okay, 6, 7 is not bad for a scale of 10. My next question to you guys would be, do you know how to order a peripheral smear at Mount Sinai West? Okay, I see a no. No. Okay, great. We should rectify that towards the end of this talk. And finally, do you know, Darren Kong is asking me something to do with the downtime form. No, things have changed for the past 1.5 years. You don't have to put in a downtime form, so I'll talk to you about it. And finally, do you know the antimicrobial prophylaxis for neutropenic states? I hear a yes. Yes, excellent. So I'll go easy on you guys for that talk, that part of the talk. Okay, great. So just back to basics for a very little bit, because you know I saw scores of 3.5 out of 5 and 6 out of 10 for how to interpret a differential count in CBC. So these are all pretty basic. What I do when I see a CBC, especially if I'm looking at someone with a high suspicion for hematological malignancy or any form of abnormality for that matter, is to examine each lineage separately and also quickly, because you can't take too much of time to like dwell on each thing. I first look at the erythroid lineage, in which you can see the hemoglobin, hematocrit, red cell indices, which is the mean corpuscular hemoglobin, mean corpuscular volume. Mean corpuscular MCHC is not really much used in the modern hematology setting, but it's just good to like scan. Reticulocyte count and RBC mass. RBC mass is my least important and least favorite of the erythroid lineage, because it just doesn't give you much actionable information. It just tells you whether the patient is dehydrated or in polycythemia vera, whether I need to phlebotomize the patient or not. I next look at the WBC lineage, in which you look at the total WBC count as well as the differential. We'll go into that in a little bit of detail, but what I want all of you to know is how to look at an absolute neutrophil count. Now, we are all pretty spoiled. Epic does an Epic reports WBC as from an automated counter. So all of the results that we have is usually automated. In Epic, when you look under labs, you may just see CBC, but always be sure to order CBC with differential. And then you pull up under the hematology tab of labs, you look under differential, and then you can see neutrophil and a hash sign, which is the absolute neutrophil count. Let's say you're working in a health system in future, or if you're in the outpatient setting or you're doing an elective, in which they don't give you an automated ANC count. So the way you calculate that is you multiply the total number of WBCs to the sum of percentages of neutrophil and bands, and you divide it by 100. That's how you can manually do an absolute neutrophil count estimation. And then, of course, I run my eye over the platelet count to see if there's any pseudo-thrombocytopenia, true thrombocytopenia, and the severity of thrombocytopenia. In special circumstances, your eyes must go to the LDH indirect bilirubin, which you normally you have to order LFTs for that. If you order a comprehensive metabolic panel, it will just give you the total bilirubin. But if you order BMP and LFT separately, you will get total and direct, and then you can like subtract that and calculate indirect bilirubin. Haptoglobin as well as ferritin. Now, LDH, indirect bilirubin, and haptoglobin are very, very sensitive markers for hemolysis. So that's how you very quickly interpret a differential count in CBC. And just to go into definitions, leukocytosis refers to the increase of peripheral blood neutrophils to about 2 or 3 above standard deviation, which is almost to anything more than 11,000 WBCs. You can potentially call it leukocytosis. The term hyperleukocytosis is not a loose term. We typically use it when WBC count is more than 100,000. Leukostasis is nothing but symptomatic hyperleukocytosis, in which the elevated WBC counts manifesting decreased tissue perfusion, which leads to microvascular obstruction and tissue hypoxia and infarction. That constellation is called leukostasis. You may have heard of granulocytosis. It's often used interchangeably with neutropenia. It's a pretty wide term that can also reflect increased eosinophils or basophils. I'm sure you've heard of left shift from all our USMLE Step 1 and medical schools. It's a pretty loosely ill-defined term that as hematologists we do not use, that kind of refers to an increase in percentage of band forms, and it's generally accompanied by metamyelocytes and myelocytes. And finally, leukemoid reaction, one of your differentials for leukocytosis. The definition for leukemoid reaction is when there's a total WBC count of more than 50,000 for a process other than leukemia. Majority of these cells will be mature cells, which are neutrophils and often accompanied by an increased number of band forms, metamyelocytes or myelocytes. So these are the definitions, the basic definitions that you should know as we move on. So what are the etiologies of leukocytosis? Really quickly, again, differentiating within the Wbc lineage, if you just tease out. For neutrophilia, it's the most common form of leukocytosis. It can be autonomous, which is driven by a malignancy, versus reactive, which is in response to infectious or inflammatory processes. Spurious neutrophilia can be seen in when patients have clumping, like platelet clumping, or patients have high protein in their plasma in mixed cryoglobulinemia. You can get spurious neutrophilia. Primary neutrophilia is often seen, as I mentioned before, in malignancies, typically in myeloproliferative neoplasms like chronic myeloid leukemia, polycythemia vera, essential thrombocytosis, in genetic conditions like leukocyte adhesion deficiency, chronic neutrophilic pneumonia, and also in Down syndrome. Down syndrome is associated with chronic neutrophilia. Unfortunately, Down syndrome also has an 11% elevated risk for developing acute leukemia by the time they hit their 3rd decade of life. Secondary causes of neutrophilia: infections, as you all know, medications, of which you should always remember is any person on steroids, any form of steroids due to leukocyte demargination can cause neutrophilia. Granulocyte colony stimulating factor, you guys might know it as Neupogen, Neulasta, Zarxio. These are all brand names for GCSF. Plerixafor, it's unlikely that you will come across it unless you are rotating in the bone marrow transplant setting with us. It's a peripheral stem cell mobilizer that we use for mobilizing stem cells for bone marrow and CAR T cells. Any patient on catecholamines, in a non-septic patient in the ICU for some reason, if they receive catecholamines, you can have, again, leukocyte demargination, because catecholamines are essentially steroids, and then you can have neutrophilia. A patient on lithium, patients on bipolar affective disorder, they are often present. We often get a consult for neutrophilia, and we see that the patient is on lithium. So that is something to keep in mind. And then for APL patients, acute promyelocytic leukemia patients receiving ATRA, all trans-retinoic acid, can also cause neutrophilia. And also stress. Lymphocytosis. Lymphocytosis is typically, absolute lymphocytosis is typically seen in CLL and in other autoimmune diseases. Monocytosis is usually associated with mostly infections like brucella, varicella, tuberculosis, malaria, typhoid, syphilis, and other malignancies like CMML, chronic myelomonocytic leukemia, CML, acute myeloid leukemia, and also Hodgkin's lymphoma. Eosinophilia, as most of you know, is associated with allergies, parasitic or helminthic infections, and also malignancies like CML, Hodgkin's. Acute eosinophilic leukemia, very, very rare. I've just seen one case of it in my entire I would say residency and fellowship combined, and also systemic mastocytosis, which is actually more common than you think. Basophilia, the causes often overlap with EO, so I don't have much to talk about that. Moving on, what I want you to take away from today are a few points, and this slide is pretty important. Not all hyperleukocytosis behave the same at similar thresholds. Like if you get a patient with acute myeloid leukemia, a patient who is coming to you to the emergency department with a blast crisis of like 60,000, 70,000, and even like at 100,000, they would be pretty symptomatic, and their leukocytosis can be symptomatic, which means they can have leukostasis. On the other hand, you are called for an admission for a CLL patient, and the CLL patient is someone who's been on chronic ibrutinib or acalabrutinib. They ran out of their pills, or they forgot to take their pills, and now they're coming with a leukocytosis of like 85,000. It's not someone I would worry about for leukostasis, because the CLL cells are very small lymphocytes. They do not stick to the arterial or venous walls as much, and they do not cause leukostasis unless they're about, like, I would say for CLL around 350 or 400,000. So that the clinical indication, because of the size of the cell, is pretty important. CML patients, again, because these are mature cells, they do not have any symptoms even at higher WBC thresholds. So what are the clinical features of leukostasis which you should be aware of? Patients complain of end organ issues like headache, blurry vision. Some patients actually present in like an acute stroke, cardiovascular incidents like myocardial infarction, and even idiopathic renal failure with a very high WBC count. How do you manage leukocytosis? Now, I'm going to pause here without it being too didactic, and can anyone just shout out or put in the chat how you have seen leukocytosis, malignant leukocytosis being managed, non-infectious malignant leukocytosis? Give me anything.
Steroids.
So someone coming in with WBC count of 40,000, you would give steroids. Steroids itself can cause.
Yeah, that was something I was like wanted to ask you, because it just finished at Sloan recently, and a lot of times we treat a lot of the leukocytosis with steroids and like ponatinib or hydroxyurea. I saw someone use as well. So I was unsure of how that mechanism worked, and I was hoping you could clarify that.
Absolutely. I think it's an excellent point that you bring up. So steroids, in an undifferentiated leukocytosis, you never give steroids because you do not have a diagnosis yet. Steroids typically are lympholytic, meaning it has nothing to do with the myeloid lineage, right? You know, if an AML person comes or a CML person comes, there is no point in giving steroids. The patient that you saw was probably like an ALL patient or someone on the lymphoma service, because they are typically lympholytic. You mentioned ponatinib, so they are possibly like a pH positive B ALL patient you saw, for which you give that for cytoreduction. But that steroids is given only after the establishment of a diagnosis. You do not, in an undifferentiated patient, give steroids because you don't know what you are dealing with. Okay. Okay, you mentioned hydroxyurea. Someone in the chat also mentioned hydroxyurea as well. Excellent. That is our go-to drug for an undifferentiated leukocytosis, which of malignant etiology. When we suspect, hydroxyurea is our go-to drug. The starting dose and you guys don't have to memorize the starting dose. This is something that as oncologists, we order on our behalf. We usually go for 3 to 4 grams per day. And if someone is already like acute leukemia patients can have hyperproliferation of white blood cells, but then anemia and thrombocytopenia due to bone marrow packing. So in such cases, we do not give 3 to 4 grams. We go for hydroxyurea like 1 to 2 grams. Other cytoreductive therapy after the establishment of diagnosis is induction chemo. So AML, it's 7+3, like daunorubicin cytarabine or idarubicin cytarabine, single agent cytarabine and hydroxyurea. Again, all these are cytoreductive therapies that we give. And finally, when someone is actually in like a leukocytoclastic crisis, when someone has leukostasis, no amount of chemo or hydroxyurea can bring down the cells fast in time. Like someone's actually undergoing like acute renal infarction, acute myocardial infarction. There's no other go but to do what we call leukapheresis. I have had to go to the hospital and set up leukapheresis for a couple of people. It's a true medical emergency. It's contraindicated in patients with APL, acute promyelocytic leukemia, because it's highly sensitive to chemotherapeutic agents like ATRA and ATO, which differentiate these cells. And as soon as these APL cells differentiate into smaller cells, they do not cause leukostasis symptoms again. Again, this is very important why you should involve hem-onc from the beginning when you have a patient with leukocytosis and leukostasis. So for leukapheresis, what do you actually do? You have to have the patient prepped with a large lumen catheter. Ideally, a double lumen dialysis catheter or a Cll catheter needs to be placed, and blood bank needs to organize pheresis. As part of arrangement, my role is often to call the blood bank resident or attending on call. Let's say, and just as a disclaimer, most of us cover only Mount Sinai West. We do not cover Morningside. So if at all you do get a patient at Morningside, you can always inform the attending on call and try to get the apheresis resident by going to Amion and pathology MSH and finding the resident and the attending. All the apheresis attendings are super helpful. They are there 24/7, and this is something you should do. Switching gears a little bit, that's all I wanted to talk about leukocytosis, again, from an intern's perspective. Just switching gears now to neutropenia, and switching gears to how immunity is linked to our system. We all know that there's humoral and cellular immunity. Humoral, the Latin term, refers to anything in the plasma. So essentially, B cells floating in the plasma, releasing immunoglobulins, the complement system, the lysozymes, they all confer humoral immunity. And what interferes with this humoral immunity? Decreased immunoglobulin production, like lymphoproliferative diseases, CLL. CLL produces massive amounts of lymphocytes, but they are deficient. They cannot produce immunoglobulins. Same goes with myeloma. Myeloma is a hyperproliferation of mature plasma cells, but these plasma cells are deficient. They cannot produce infection-fighting immunoglobulins, so hence your humoral immunity goes down. Intensive chemotherapy and XRT also drops your humoral immunity. Cellular immunity, again, as you all know, is conferred by T cells, phagocytes, and natural killer cells, and they, in fact, tackle intracellular pathogens. These can be, the cellular immunity can be interfered by, again, cytotoxic chemotherapy, total body irradiation, which is extensive XRT, immunosuppressive medications, monoclonal antibodies like alemtuzumab, it's an anti-CD52 antibody, rituximab, it's an anti-CD20 antibody, purine analogs like fludarabine, cladribine, etc. So what is truly the infection risk in cancer patients? And this is something for you guys to have a quick idea when you're seeing patients. We consider most patients receiving chemotherapy for solid tumors as having a low infection risk. And that is because any of the chemotherapeutic medications we give for the treatment of solid malignancies, their ability to cause neutropenia lasts less than 1 week, which is why they're considered low risk. Patients receiving autologous stem cell transplant, lymphoma patients, myeloma patients, CLL patients, their regimens are myelotoxic and lymphotoxic. However, the anticipated neutropenia period is from 7 to 10 days. Hence, they are in the intermediate risk category. The high risk categories are new diagnosis of acute leukemia because they're extremely pancytopenic, or hyperleukocytosis with functional neutropenia. Acute leukemia patients undergoing intensive induction chemotherapy, consolidation or maintenance chemotherapy, allo transplants, allogeneic stem cell transplant, including cord blood transplants. And also for these patients, the anticipated duration of neutropenia is more than 10 days. So this is how in our world we see infection risk. Solids, non-leukemic or non-allo transplant all goes to intermediate, and high risk is the allo transplants in leukemic patients. So as you can see in this graph, as the infections per 1,000 days increases with absolute neutropenia. On the x-axis, you can see the WBC count, and y-axis is risk for infection. So what again are the risk factors? What contributes to infections in these neutropenic patients? Your skin is your biggest barrier against all infections. So when there's a breakdown of skin barrier, which is when you have a central line placement, even little blood draws in neutropenic patients. When we do bone marrow biopsies, the bone marrow biopsy sites, radiation damage or surgical wounds, all of this can cause damage to the skin barrier, and gram-positive organisms are often found in skin and soft tissue infections like MSSA, MRSA, coagulate negative staph, and corynebacteria. The next most important and perhaps what I have seen the most fatal of all infections is that when the mucosal lumens are affected, specifically the GI tract, the ureters, bile ducts, etc., causing cholangitis, septicemia, typhlitis, and UTIs. These are predominantly gram-negative and fungal infections, as you can see in this table. For breast cancer patients and melanoma patients who undergo sentinel lymph node biopsy or axillary lymph node dissection, that again is a form of skin and soft tissue infections. They are susceptible to gram-positive infections. And finally, patients with asplenia, whether it be iatrogenic or functional asplenia, they are susceptible to encapsulated bacteria, and they can cause overwhelming sepsis. So what are these bacterial pathogens in neutropenic patients? And this is very important when you go for medicine boards, because I was looking forward to a lot of questions from hematology oncology for the board. Sadly, very few came, but this was asked. Like neutropenic fever was extensively asked. So you should know the gram-positive cocci that normally are seen in neutropenic patients are coagulate negative staph. It's not MSSA, it's not MRSA, it's coagulate negative staph, which is your skin flora. There's also viridans group of streptococci from your oral flora, Streptococcus pneumoniae, and also Streptococcus pyogenes. Gram-negative rods, which cause overwhelming sepsis, the most common cause is E. coli, including ESBL and CRE producing E. coli, Klebsiella, Pseudomonas, Enterobacter, Citrobacter, Stenotrophomonas, and Acinetobacter, which is usually multi-drug resistant. So fever and neutropenia. Why is neutropenic fever such an emergency? Why do you guys keep hearing your attendings and your fellows just keep telling you this is an emergency? What is your understanding?
Well, basically, it's a probable infection or likely of infection in a patient that doesn't have an immune system.
Mm-hmm.
So it's,
exactly.
That's why it's an emergency.
Correct. So there were, thank you. So there were a lot of studies that looked at, centers that did not institute antibiotics in a timely manner versus centers that did. And they found that there is an unacceptably high, over 80% risk of mortality if you do not initiate antibiotics within the first hour of fever. That is why we harp on about initiating antibiotics at the right time for neutropenic fever. So just moving on to definitions that you should know about, and I'm sure you've heard of this, again, when you rotated on the onc floors from your fellows or from your attendings. Neutropenia, the definition of neutropenia is usually an absolute neutrophil count of less than 0.5. But even for neutropenia, there are grades of neutropenia. What we call, the other definition of neutropenia is when the ANC is expected to decrease over less than 0.5 in the next 48 hours. The grades of neutropenia are mild. When the ANC starts dropping less than 1, all our antennae go up, we know that this person is going to be neutropenic, so we call it mild neutropenia. Moderate is actually when the ANC is less than 0.5, and profound neutropenia is when the ANC is less than 0.1. So these are the definitions for neutropenia. And what is the definition for fever in neutropenic fever? It's either a single elevated temperature of more than 101 Fahrenheit or an elevated temperature of more than 100.4 lasting for at least an hour. So taken these together, this is the definition of neutropenic fever. As discussed before, neutropenic fever is an emergency because of the extremely high mortality from usually gram-negative bacteremia. And it needs antibiotics at the onset of fever. Even if you're seeing a patient in the outpatient setting, they're coming to your clinic, they're getting cancer chemotherapy, don't wait to give them antibiotics until you send them to the ER. If you're in clinic, ask them to take like 1 dose right then and there, and then send them to the ER. If they're calling from home, prescribe them levofloxacin or ciprofloxacin and Augmentin, and then send them to the ER. It's unacceptable for someone to wait at least 3 to 4 hours after the onset of neutropenic fever to get antibiotics. Differential diagnosis, I will not do the pop quiz on this one, but some things to keep in mind are chemotherapy-induced mucositis, tumor fever or cancer fever itself, transfusion-related fevers, because these patients are pancytopenic, we give them a plentiful blood transfusions, drug fever from any other drug they might be receiving, venous thromboembolisms. As you can remember, they are a huge cause for non-infectious fever, someone with cerebrovascular accidents or adrenal insufficiency because we give them a lot of steroids. In the bone marrow transplant world, there are a few other causes of fever that we often think about. One is engraftment fever, when the blood cells go into their nadir, and when they come back up, we often see a fever. It's called engraftment fever. Graft versus host disease, bronchiolitis obliterans syndrome, which is nothing but lung GVHD, and sinusoidal obstructive syndrome. The previous name was veno-occlusive disease. So these are causes of fever in the bone marrow transplant setting. The risk of neutropenic fever, as I mentioned before, solid tumors is 5 to 10%. Non-leukemic heme malignancies, which is the lymphomas and the myelomas and auto transplants, it's usually 20 to 25%, but as you can see in acute leukemia, it's 80%. Okay, so susceptibility factors, I think we went through most of it, but just wanted to draw your attention to, in solid tumors, physical obstruction of airways, intestines, ureter, or biliary tract by the tumor. They can cause like mucosal breakage and escape of bacteria into the bloodstream. That is often a cause for infection. Any vascular access devices, chest sports, frequent transfusions, prolonged antibiotic exposure, these are all predisposing factors. How do you risk stratify patients at risk for neutropenic fever? Well, you can pull up your trusty MD Calc app in your phones, which I'm guessing all of you have as residents. And earlier on, we used to use what is called the CISNE score, the Clinical Index of Stable Febrile Neutropenia. It's not used now because there's a much more validated and widely accepted score called the MASC score, the Multinational Association for Supportive Care in Cancer Risk Index score. It's a composite score of all these endpoints, and you can manually calculate it or input it into MD Calc. A score of more than 21 is low risk, but if someone gets less than 21, that's like a high risk. How do you go about diagnosing neutropenic fever? You have to get 2 sets of blood cultures, one ideally from periphery, one from the central line or Hickman catheter. Chest X-ray and UA, we often do it in clinical practice. We will tell you to do so, but if you look at IDSA guidelines and also your MECSAP or UWorld questions, it's not routine. It's only ordered if the patient is symptomatic. And again, this is mostly over at MSH. The RN may call a rapid response based on abnormal vital signs on the onc floors. Do not forget about the exam, guys. This is super important. Anyone with a neutropenic fever, like I mentioned before, skin and soft tissue exam, extremely important. Always have a look at their vascular access sites, whether they have a tunneled catheter like a Hickman catheter, have a look at the Hickman site. If they have a chest port somewhere, look at that. ALL patients and high-risk lymphoma patients have something called an Ommaya, and Ommaya is a CNS reservoir from which you take CSF. Ommaya catheters, Hickman, chest ports, always have to look at those sites. If someone had a bone marrow biopsy from us 2 days ago, look at that site. If the patient tells you they had an LP a couple of days ago, look at that site. Look at the lower extremities for cellulitis. A lot of patients have perirectal abscesses, and in fact, we actually lost one patient recently because of Klebsiella bacteremia from an undetected perirectal abscess, which was not detected during admission. Ecthyma gangrenosum, it's a skin infection from Pseudomonas, and also this image shows the importance of looking at the bone marrow aspiration site. Coming to management, as I mentioned before, you look at the MASC score. If the MASC score is more than 21, we generally consider them as low risk, especially like if they're a solid oncology patient, lymphoma, myeloma, they're coming to you with mild neutropenia and fever. You can manage them in the outpatient setting in the clinic, or you can admit them to the hospital for 24 hours and give them a fluoroquinolone-based therapy and augmentin. This I'm talking about only PO medications. If you want to manage them PO, it's dual antibodies, fluoroquinolone along with augmentin. This is a MECSAP question. It's not single agent treatment anymore. If a patient is coming from the outpatient setting with fluoroquinolone prophylaxis for neutropenia, do not put them on fluoroquinolone, just switch straight to cefepime. Coming to our high-risk patients in which the MASC score is less than 21, the drug of choice is, at least in the Mount Sinai system, it's usually cefepime. I've been in other health systems, and you guys do rotate in Sloan as well. Their choice, according to their antibiogram, is Zosyn. So other accepted monotherapies are ceftazidime, piperacillin tazobactam, which the brand name is Zosyn, and also carbapenem. So the core is that Pseudomonas is the most feared gram-negative organism that we are targeting with these IV antibiotics. So any anti-Pseudomonal IV antibiotic should be first line for high-risk patients. When do you guys add on vancomycin? Now this you know, having been in March of your intern year. When do you add vancomycin to this mix? What are the indications? I know that the ED will give you vancomycin, but traditionally no. You should be starting with cefepime. Okay, I see the chat popping up. Skin lesion, mucosal damage, excellent. Prior MRSA, central line, amazing. I think you guys are getting most of it. Something, recent hospitalization, yes. Lung and hemodynamically unstable, exactly. Severe pneumonia, correct. So the most indication in my mind to add on vancomycin if the patient comes in with hemodynamic instability and if there is radiographic evidence of pneumonia. That's an indication that we all miss, but this is core IDSA guidelines that we should all know about. Hemodynamic instability, radiographic pneumonia, positive blood cultures for gram-positive cocci, even before speciation or drug sensitivities, add on vancomycin. Anyone with a suspected CLAPSI, a central line infection, anyone with skin and soft tissue infection, with a history of MRSA colonization, mucositis, and also patients who come from the outpatient setting with prior fluoroquinolone prophylaxis, these are the patients you should add on vancomycin. So, this is a clinical scenario which hopefully a lot of you won't see because we don't have a lot of heme malignancy patients at Mount Sinai West. But if you do rotate at Sloan or if you come to Sinai and rotate with us, you'll see that there are patients who do not respond to 3 to 4 days of cefepime or Zosyn or whatever you give at them. So now is the time to reevaluate why these patients are not responding, reculture them, pan image them, ID consult for sure, broaden the antibiotics, and this is the time when we introduce preemptive or empiric antifungal treatment. That in itself is a whole different lecture, so I'm happy to talk about it later, but the take-home point which I want you to remember is more than 4 days of persistent fever in a neutropenic patient getting anti-pseudomonal therapy, add on antifungal. How long do you keep these antibiotics for? So when the patient is afebrile for more than 48 hours and when the AMC climbs back up to 0.5, that's when you can consider de-escalating antibiotics.
Sorry, I have a question.
Sure.
On the low risk. So if patients are already in fluoroquinolone prophylaxis and they come to the outpatient setting,
correct,
which dual would you do for augmenting and what else?
You can do augmentin or fluoroquinolone because someone who's that is why you should send the patient to the ER for admission for like at least a single day of cefepime 2 gram Q8. You should give them like 24 hours, or we have what is called as you can always send the patient over to Sinai. Like we have something called the OCU, Oncology Care Unit, in which these patients are admitted and they get like 24 to 36 hours of IV antibiotics and observation, and then they're sent home. So and not all patients are on fluoroquinolone prophylaxis. So I'll tell you which these patients will be, but that's a good question. I think we're coming right to that. So excuse my typo, it's supposed to be IDSA guidelines on antimicrobial prophylaxis. So for antibacterial prophylaxis, IDSA typically only advises for high-risk patients, the patients who are receiving induction, consolidation, maintenance therapy for acute leukemia and allotransplant patients. It's only for high-risk patients that prophylaxis with outpatient fluoroquinolone should be considered. However, local antibiograms must be monitored for resistance, and the drug of choice is usually, we use levofloxacin. I've never seen ciprofloxacin used in our BMT or leukemia clinics, but levofloxacin is our drug to go. The low-risk patients, which is everyone else, lymphoma, myeloma, autologous stem cell transplant patients, MDS patients, none of them typically in the outpatient setting get fluoroquinolone prophylaxis. So for these high-risk patients, when the ANC drops to less than 0.5, we start fluoroquinolone prophylaxis. Antiviral prophylaxis during the period of neutropenia in all patients. For HSV seropositive patients undergoing stem cell transplant, or for all patients undergoing leukemia induction therapy, we give acyclovir prophylaxis for 1 year. And patients at moderate to very high risk of hepatitis B reactivation should receive prophylaxis with either tenofovir or entecavir. Moving on to antifungal. So the need for antifungal therapy stems from there's an extremely high risk of invasive fungal infections in heme malignancies, typically IFI in the lungs and the liver. You can see histoplasmosis and aspergillus like disseminated in the bloodstream as well as these solid organs. There's a huge difficulty in establishing early diagnosis because your blood indices like galactomannan and other markers are not usually sensitive. You should go for a tissue biopsy to see the fungal elements. And most importantly, outcomes for patients are extremely poor if mold active antifungal agents are delayed. So here as well as with antibacterial prophylaxis, a global approach is not appropriate because antifungals are not benign drugs. In fact, they're much more toxic than antibiotics. And there is an emergence of resistance that could outweigh any benefit you would give these patients who are at low risk. So my take-home points for you both will be, but for you guys will be antifungal, the patients at high risk, we give fluconazole as a starting treatment. Only for allotransplant patients and leukemia patients, we give voriconazole, posaconazole, or isavuconazonium, depending on some indications. And the choice of these newer generation azoles is dependent on what other ancillary medications they're on. There are many drug-to-drug interactions we keep in mind when we go on to choose vori, posa, or isavuconazole. It's also called Cresemba. Echinocandins like caspofungin, micafungin, anidulafungin, we only use if the patient is has a demonstrated resistance to fluconazole and we need candida coverage. Amphotericin B, honestly, IDSA mentions it. I've never seen it used as a prophylaxis, but rather as a treatment for IFI, like for histoplasmosis. Since we were talking about neutropenia, I feel it's pretty bad to leave out lymphocytopenia, which is something you can often see on the inpatient setting. Common causes for lymphocytopenia includes infections like viral infections, most commonly HIV, COVID, influenza, measles, hepatitis, bacterial infections like TB, typhoid, and brucellosis, classic for lymphocytopenia, fungal, histoplasmosis, and malarial infections. Iatrogenic, something to keep in mind, glucocorticoids when given in lymphoma patients will not cause an increase, but rather a decrease in the lymphocytes because they're lympholytic. ATG and alemtuzumab and rituximab, these are also immunosuppressive agents. Alemtuzumab anti-CD52, it's used for CLL, and also one indication which I remember from internal medicine is I think relapsed refractory multiple sclerosis. You give alemtuzumab, rituximab is anti-CD20, lymphodepleting chemotherapy like fludarabine and cytarabine, and all patients with stem cell transplant. Total body irradiation, extremely lympholytic. Patients who receive TBI often have lymphopenia for like a year or 2 years. Systemic diseases like sarcoidosis, renal failure, Cushing syndrome, malignancies like lymphoma, aplastic anemia, congenital immunodeficiencies, and of course other reasons like zinc deficiency, alcohol, malnutrition, stress, and protein-losing enteropathies, all of this can cause lymphocytopenia. Now coming to, I put this together specifically for you guys keeping in mind, these are things that I wish I knew as a resident when I was taking care of these patients at Mount Sinai West. And so I just put together some collective experiences that I have put together, which I realized will be useful for you guys when you guys call us for consults. Any new diagnosis of acute leukemia, a patient comes to you, high WBC counts or low WBC counts, pancytopenia, you are suspecting acute leukemia and you have no confirmation whatsoever, doesn't matter. It is a hem-onc emergency and please call your hem-onc fellow on call if you're at West. If you're at St. Luke's, I think it's either Dr. Dar or Dr. Devalaptuni. So what should you guys do? What should residents do when you get a patient in whom you suspect acute leukemia? What are the initial investigations that you should do in which you can help out your friendly hem-onc fellow? First, call the hem-onc, whoever is on call. There is 24/7 fellow coverage at Mount Sinai West. You can look that up in Amion. St. Luke's, as I mentioned before, is covered by attendings. Any of these patients, we do not have an inpatient leukemia service or an inpatient lymphoma or myeloma or BMT service at West or Luke's. So we normally initiate the transfer to MSH. Nothing that you guys have to do unless the fellow or the attending asks you to do. Usually we call the transfer center and we initiate the transfer. always send a peripheral smear. And this is why I asked you in the beginning, do you guys know how to order a peripheral smear? I have a separate slide for it later, so I'll come back to that. Mandatory labs, and this is something which will be very useful for you on the internal medicine wards. CBC with differential. Unacceptable to have a leukemia patient without a differential every single day. Coags and fibrinogen are mandatory, at least in the first initial few days, because we are trying to see, we don't get a diagnosis of what type of leukemia it is until we have flow cytometry and cytogenetics back, which is like 24 hours later. So in order to make sure the patient's not in DIC from a probable APL, coags and fibrinogen are mandatory. CMP, although like I mentioned before, I'm not a big fan of CMP, I would rather order them as BMP and LFTs in EPIC. These are the other peripheral blood studies that you can send, which can help us cinch the diagnosis of what kind of leukemia this could be. FLT3 mutations, NPM1 mutations, CBPA mutations, BCR-ABL PCR if you're suspecting CML, and also JAK2 if an MPN is being suspected. Infectious workup again needs to be sent as part of admission labs, which are HIV, hepatitis B, hepatitis C, strong eloides, toxoplasmosis, T-cell rearrangements, and B-cell IgH rearrangement. I mean, this is an order set which you can like memorize or note down somewhere. And the importance of all this comes in when we are actually treating the patient. Suppose you get a patient overnight and the patient is pending a bed transfer. You should have the nurse get ready 2 green top tubes, one which we use for flow cytometry, one for cytogenetics, and one purple top tube which we send for next gen sequencing, neogenomics or foundation. At Mount Sinai West, usually 1 green top suffices. We usually do not want to waste the other green top or the other purple top because the patient will be eventually transferred to Mount Sinai Hospital. But again, it's very helpful if you get that 1 green top and send it off for flow cytometry, because you can always, because flow cytometry I think is read at Mount Sinai West. I think Dr. Fan and Sharabi, they read flow cytometry, but all the others are done at Mount Sinai Hospital. Again, if the patient is pending, like you may have a patient who's on your service who's not yet gone to Sinai because they're pending a bed assignment or they're medically unable to, they usually should get a bone marrow biopsy. The attending or fellow on service will do it the next day. How to check a peripheral smear? Okay, so now at Mount Sinai West, someone talked about a downtime form. You do not need a downtime form anymore. There's an EPIC order. The EPIC order is called HEMONC slide request. In HEMONC slide request, when you put that in, there's a hard stop called slide tube to station. Just type in will pick up in lab. And then it's usually helpful. So to call the MSW HEMONC lab, I mentioned the number here. You guys don't have to do it. As fellows, we do it. But if you do it, it saves us a lot of time, which is why I'm putting this here. But at least if you can order and call the lab, it's very helpful because they will prepare it as soon as we come and see the patient. And if you want to ever see the smear, you can always come with the fellow, or you yourself can go. The heme lab is actually on the first floor. Just walk past the cafeteria. The door code for the lab is 5231. The text would have laid out your peripheral smears, and you can just sit on like high resolution microscopes and look at your patient's smear. It's as easy as that. MSH, again, if you're ever rotating with us there, the order is the same, HEMONC slide request. In that hard stop within the order set, you just say tube station to 211. That's where our fellow's room is. How do you look under the microscope? You first look in low power without oil at 10x, just to get the lay of the land, and go up to 50x. And finally, you put oil for oil immersion 100x. At least a minimum of 10 to 15 fields should be checked for the presence of promyelocytes, because APL is a diagnosis we never want to miss. And bonus, again, I'm not expecting you guys to do, but again, bonus, we do it whenever we see like picture, we try to take a picture through our phones and we put it in media so that we can then auto-populate it to a note. Again, you guys are not expected to do that. Yeah, I think I reached the end of my talk. So just some take-home points for you. Leukocytosis has very broad differentials. All acute leukemia suspects need an emergent HEMONC consults, and watch out for signs and symptoms of leukostasis because you may need to initiate hydroxyurea or leukapheresis. Neutropenic fever is a true HEMONC emergency with an unacceptably high mortality rate if empiric treatment is delayed, and your empiric treatment includes broad spectrum gram-negative bacteria coverage, especially for Pseudomonas, and add on vancomycin per the indications we discussed. And finally, specifically for you guys, workflow specific, you should know when to call your fellow or your attending. You should know ideally how and when to order peripheral smears. And also you should know the initial workup of acute leukemias and neutropenic fever. And with that, I have left 10 minutes for any question and answer sessions. And thank you all for your time and for inviting me. It's lovely to be back at your alma mater.